All right, so we're in here. I want to welcome everybody to Trump and the Global Economy, Trump and the G for short, where we discuss issues important to the economy and the community. And I'm Shock Exchange, and I'm the founder of Trump and the G. And my background is more finance and economics. I spent about a decade doing corporate M&A. I'm known for a book called Shock Exchange, where I basically wrote about the economy and working with these kids in the neighborhood pursuant to financial literacy. I also write for a financial website where I cover a bunch of healthcare stocks, some of which are impacted by the opioid litigation. So we just go around the room. We go with Amarquaye, who's a pharmacist, who's gracious enough to actually speak on the platform.
Thank you so much for having me on. I really appreciate it. Like you said, my name is Dr. Amarquaye, and I am a clinical pharmacist who works in Florida right now. So I take care of both acute and chronic patients, and I've kind of had a passion for like the opioid epidemic and the opioid crisis, just understanding the nuances of that and talking about that over the years. And of course, Dr. Kolodny's name has popped up, many times. And, just once again, thank you for having me on, and I hope we'll have a great discussion today.
Okay, let's go to Dr. J. Joshi.
All right, thanks for having me. My name is Dr. J. Joshi. I'm a general practitioner in Northwest Indiana. I have both medical and legal experience with the opiate epidemic. Medical in that I was working with the state of Indiana to develop innovative healthcare models that would help address substance use dependency in the community. I was subsequently indicted on one count of prescribing Norco outside of the scope of medicine. So from there, I developed a legal experience in the opiate epidemic, and going through that ordeal has really taught me the discrepancy, willful or unwillful, between the clinical world and legal world and how they're looking at the opiate epidemic. And now that I've resumed practicing, I've really been able to kind of leverage that legal insight into clinical care and policy change for the opiate epidemic.
Okay, Mr. Mitchell.
So I'm still here. You guys can see me. I can see William and Mr. Mitchell.
Wondered that we have a little bit of technical issues, but if everyone can hear and see me, I'll just kind of pick up where you left off, Dr. Joshi and Dr. William. Can you pronounce your last name for me again, Dr. William? Amarquaye. Okay, I didn't want to mispronounce it. So one, I'll just welcome you gentlemen. Welcome you gentlemen again. Appreciate you taking the time to join us here. And one makes it makes us feel like we're not alone, because we have probably been covering opioids, but from an economic standpoint, for the better part of 3 years. And over that time, voices come and go, narratives come and go. But a lot of the times it can kind of feel like you're screaming on an island by yourself a little bit, right? So one of the things that we like to do is just kind of connect some of the dots, not only for investors, but just general listeners. I like to kind of get away from the 30,000 view and kind of the large S words and put it in a very practical sense. And one of the things that we have really been able to sparse is making that connection of what has been happening to our community. We're old enough to remember what was happening throughout the 70s through the 90s. Perfect. So, Chuck Stang, I can see your back. How's your audio? I'm getting some.
Can you hear me? Can you hear me?
Perfect.
Okay, great. I don't know what happened. I must have got kicked off by accident. So I had to rejoin. Sorry about that, guys.
No, perfect. You can just kind of pick up, give us a brief. I was just getting ready to roll into a brief synopsis of what we've been covering, and then to open the floor up to our esteemed guests.
Okay, so basically, you know, I don't know how much you gave him about the overview, but you know, Trump threw down the gauntlet for the opiate epidemic in 2017 and said that you know the proliferation of opiate pills coincided with with drug overdose deaths. So they made the connection, and so he said these big pharma companies were going to pay for their role in the opiate crisis, and that led off a bunch of lawsuits. And then in 2019, there was multi-district litigation that was set up by Judge Poston and a bunch of plaintiff lawyers that created a mechanism to settle these cases, a novel settlement mechanism where they could make sure that the money would go where the harm occurred with the municipalities and the cities. Then in 2020, Trump actually settled with Purdue Pharma right before the election. There were a few test cases in 2019 with Oklahoma and a few counties in Ohio. The lawsuits in Ohio never went to trial because they were settled, and the lawsuits in Oklahoma were settled too, except for Johnson & Johnson, which went to court, and the judge actually ruled against Johnson & Johnson, said they created a public nuisance with all these pills being distributed in Oklahoma. So those were the first two test cases, and then in this past summer there was actually a global settlement between Johnson & Johnson, McKesson, Cardinal Health, and AmerisourceBergen, with about 42 states. So it was about $26 billion global settlement. And then the other development was that last month, California ruled that opium manufacturers could not be held liable for a public nuisance claim because there's no evidence to support that they actually, the manufacturers actually induced doctors to inappropriately prescribe opiates. And you also couldn't tell how many people OD'd on prescription opiates versus opiates on the black market. Then within a couple of weeks, the state Supreme Court of Oklahoma overturned the previous ruling from the lower court where Judge Thad Balkman had ruled against Johnson & Johnson. State Supreme Court overturned that and said that Thad Balkman erred in how he interpreted the public nuisance claims, and you couldn't accuse a manufacturer of public nuisance, and that they couldn't be held liable for how someone used or misused their products after they produced it. And so things are I think that was a line of demarcation. So I think it may have gotten people off this narrative that opiate manufacturers caused doctors to inappropriately prescribe opiates to pain patients who became addicted and eventually OD'd or turned to heroin or the black market after they were cut off by doctors. So that changed the narrative a lot. So I'm gonna play a clip of Andrew Kolodny, an interview with him in Axios, and we're gonna walk through that. This is based on the most recent data on drug overdose deaths for the trailing 12 months through April, where drug overdose deaths increased over 100,000, up nearly 30% year over year. This came in the face of a sharp decline in opiate prescriptions. So here it goes. I'm gonna try to share my screen with everybody else. Okay.
A rare censure of a Republican lawmaker, plus a debate in Washington over who authorizes military force. But first, today's one big thing, a new record in drug overdose deaths. Drug overdose deaths in the U.S. are at a record high. More than 100,000 people died of an overdose in the 12-month period ending in April this year. That's according to new CDC data. Dr. Andrew Kolodny is here to help us understand why. He's the medical director for opioid policy research at Brandeis University. Dr. Kolodny, thanks for being with us.
Thanks for having me.
First, these numbers are for all overdoses. How much of this is about opioid overdoses specifically?
The vast majority of these drug overdose deaths are opioid, and in particular, they involve an illicitly synthesized opioid called fentanyl.
Were you expecting the numbers to be so high at this point?
Opioid overdose deaths have been skyrocketing for the past few years, and actually for more than 25 years. Each year we've been setting a record for death from drug overdose, and then the next year we break that record. But the last few years have been the worst, and I expected the numbers to continue to get worse, but not this bad.
And how much did the pandemic exacerbate this?
It's very difficult to say, but there are reasons to believe that COVID did make the problem worse. For many people with opioid addiction, which is a chronic condition, they're prone to relapses. And during times of psychosocial stress, when there's social isolation, that can make people more prone to a relapse. In the past, before the opioid supply was so dangerous, to have a slip or relapse might not be life-threatening, but today with such a dangerous opioid supply, all it takes is one slip. There are also reasons to believe that COVID may have made it harder for people with opioid addiction to access treatment. And lastly, there are reasons to believe that COVID may have led to an increase in fentanyl use in the western half of the United States. So before COVID hit, the fentanyl problem was mainly affecting the eastern half of the United States, where we mostly have powdered heroin. And in the western half of the United States, where the heroin is more in a form called black tar heroin, where it's harder to mix fentanyl into black tar heroin, we were seeing far fewer fentanyl deaths during COVID, possibly because there has been less cross-border traffic, particularly from Mexico, that may have favored the smuggling of the more potent fentanyl, and that may have led to the increase in fentanyl use. We did see the largest increase in fentanyl deaths over the past 12 months in states that had not previously had much of a fentanyl problem.
Like where?
California, Washington, Oregon. These are states where we really did see an even greater skyrocketing in deaths since COVID.
Is there anything that's giving you hope about the future of this epidemic right now?
Not really. Much of what President Biden said he was going to do about the opioid crisis when he was running for president is exactly what we do need to do. Unfortunately, we really haven't seen enough action from the administration yet. What we really need right now would be a commitment for long-term funding for treatment expansion or the creation of new funding streams so that people who are opioid addicted can much more easily access effective treatment. And when I say effective treatment, I'm not talking about rehab beds or detox. I'm talking about long-term outpatient treatment, particularly with a medicine called buprenorphine. If we really want to see deaths come down in the short run, someone who's opioid addicted has to be able to access treatment more easily than they can buy a bag of heroin or fentanyl. And until we get there, I think we're going to see very high rates of overdose deaths.
Okay. Okay. So that's the interview. But I think the first thing I noticed was that at a high level was that he kept referring to opiate addicted. So he characterized these people as opiate addicted, and some people could be addicted to opiates, they could be addicted to something else. And just because you're opiate addicted doesn't mean you're going to overdose. And then some people who could be habitual users or first time users who could overdose. I'd like each of the panelists to, first of all, discuss, why does he keep referring to opiate addicted, and then also discuss your take on the actual numbers, the actual data for the data for the overdose deaths through April 2021, the 100,000 figure.
Can we start
I'll start with William.
Well, I know you only got a few minutes on your break left. But.
So as far as the interview, I think that because I've watched a lot of his interviews and a lot of his lectures, and the way he characterizes the opioid crisis is a crisis of addiction, right? Opioid addiction. And I think that is not completely accurate because, what we're dealing with right now is we're dealing with a black market supply of illicit fentanyl, which is very potent. And not necessarily everyone who overdoses is addicted, right? So, for example, you have someone who buys something online, or you have a teen who experiments with a pill and it has fentanyl in it, and they overdose and die, right? So it's to characterize this overdose crisis as just a crisis of addiction, I think is kind of not entirely accurate, because what we're dealing with right now is like a poisoning crisis, right? So people are being poisoned by a black market supply of drugs. And it's not just fentanyl, it's also polysubstance as well. So it's many other drugs that are combined. But with fentanyl, it's so potent that you can overdose with just fentanyl. But if you look at the toxicology reports, a lot of the deaths have multiple drugs in it, right?
That's right.
So I think that we have to be careful in characterizing this crisis as just a crisis of addiction, because people are losing their loved ones because they're being poisoned, right? It's not necessarily because they're addicted. So I think we have to be careful in that.
Right.
And then as far as the numbers, as you were saying, from last April, it was like over 100,000, which is insane, which is the most we've ever seen in a year, right? And if you actually break down the numbers, it's a lot of people say, oh, the numbers are opioids. You have to kind of be specific. Like, what medication are you talking about, right? And it's you can't just say opioids. And it was actually one of the rare moments where he actually said illicit fentanyl. He actually said something right, like it's illicit fentanyl. And I actually agree with Dr. Kolodny about that. Like it wasn't just illicit fentanyl. We have to be specific when we're talking about the overdose deaths. And as I said before, I think from the data I was looking at, it's like over 80% of the deaths. Because if you look at over 100,000, that's all drugs. That's not just opioids, right? And then when you break it down,
right,
in regards to the deaths that involve opioids, over 80% of that is illicit. So it's important to understand, what meds are involved, and it's important to break down, what exactly is happening. A lot of people rely on these medications. If you have chronic pain, you can't just say opioids, because I have conversations a lot with people on social media, and they think it's just opioids from pharmaceutical manufacturers, but it's not. It's illicit fentanyl coming in from other countries. So we have to make sure that that's something that we understand.
Right, and that's why we're doing it. So a couple things. When he says that, when you say we have to be careful, we do have to be careful, and we want to be careful because we want to have the right information. But he doesn't have to be careful. Mr. Kolodny doesn't have to be careful. He's saying that he has to keep saying the word addicted, because he started out with addicted a few years ago. He said this is a prescription opiate crisis where you have patients who've been prescribed opiates who became addicted. So that's why he keeps using the word addicted, which is consistent with what he said previously. And then he has to just use the word. Then he's being generic with the word opiates, where he was very specific previously with prescription opiates, and he didn't use the word prescription on that at all during the interview. Previously, he was very specific about prescription opiate, which attaches the doctors and the opiate manufacturers and distributors. Now you never said prescription opiates. Now you're using a blanket word opiates.
Out on that.
I beg your pardon?
And I think now he's starting to understand. Like I can't just say prescription opioids. Like people are going to call me out on it. So I was kind of surprised that he actually said illicit fentanyl in that interview, which was pretty surprising to me.
Right. Okay, so let's go to Dr. J. Joshi.
So first off, I agree with everything that Dr. Williams said, and he made quite a few astute observations. The first one is characterizing poisoning from overdoses and recognizing that there's a lot of nuance in how patients and those who we may not traditionally believed to be patients are ingesting these substances. So when you state opioid addicted, you're again simplifying. And I think it's important to note that nothing Dr. Kolodny said was wrong, but it was deliberately simplified. And the error comes in the oversimplification. When you oversimplify complex concepts into convenient narratives, you eliminate the nuances of what Dr. William alluded to. He mentioned long-term access to care. I don't think anybody is disputing that. The issue really is true access for all conditions. And if you focus on just opioid addicted patients, you're missing out on the continuum of pain, dependency, and addiction. And there's a fundamental relationship that harkens back to the earliest use of pain medication. The pleasure-seeking potential of pain medications is inherent in the medication itself. So if you try to separate addiction as its own isolated construct without taking into account the pain, dependency, addiction spectrum, you're conveniently simplifying a very complex, ancient phenomenon that we as human beings have that in many ways transcends us as mammals, that goes really to our fundamental limbic system and how we internalize pain and pleasure. So I think first off, we have to understand what Dr. Williams was saying, that the issue is complex and nuanced, and we need to understand how patients are internalizing their clinical decisions to engage in high-risk behavior, to seek medical care, and understand how that pathway of decision-making may lead to an overdose death, and not simply just jump from opioid-dependent mortality. Because at the end of the day, mortality is an acute metric. Addiction is a chronic disease. And when we look at acute metrics for chronic diseases, we will not understand the true nature of addiction itself as it pertains to pain and dependency. And so what I would encourage everybody in the listening audience to do is to look at the literature, understand the complex nuances on clinical decision making that goes into a person requiring pain, a person who may be dependent, and a person who is outright opioid addicted. Not just look at the end metrics, because that's where we get into the convenient narratives, and we get these individuals like Dr. Kolodny who focus on the convenient narratives, whereas before he was saying prescription opioids, now it's the convenient narrative of opioid addicted illicit fentanyl. That is in the right direction, but it's fundamentally incomplete. And while we're trending the right way, we have to make sure that we remain focused on the complexity and the nuances of the issue at hand.
Okay. Mr. Mitchell.
Actually, if I may ask Dr. William a question, what have, in terms of practitioner, of what you do day to day, this blanket labeling, what has that done to your ability and even your colleagues' ability, maybe across different counties, other regions, assuming that, you speak to your cohorts, what has that done as far as the ability to even get folks, patients, the actual medication that they need? Has it made it more challenging? Has it made it, in other words, what have been the barriers, if any, that you've seen change over the course of time due to the labeling, like this general or this blanket labeling that anyone that comes with a certain prescription, there's the drug-seeking addict. So yeah, I'm gonna use my time to ask that question.
Opioids and stigma to them. So, before I came into the hospital, I used to work in retail, and I would see a lot of stigma in retail whenever patients come in to fill their medications, and this has been happening for years now. And I have family members who have chronic conditions that need pain medication, and it's just a hassle. I mean, if I can describe it in one word, it's a hassle. Whether it's in retail or whether you're not being treated properly. some of the nurses or some of the attendings sometimes about properly treating pain because of the stigma, and then also some of the misinformation regarding addiction, right? This idea that you're going to take pain meds and all of a sudden you're just going to succumb to addiction. But addiction is much more complex and much more nuanced and so it's been very interesting over the course of my professional career as a pharmacist, which hasn't been too long. It's been over 3 years now, but I've seen a lot of stigma when it comes to pain patients, and especially with people I know personally, having to go pharmacy to pharmacy just to get the meds that they need for their chronic condition. And it's just really sad now because kind of the unintended consequences have spilled over to patients who need that medication. But now you have people like Kolodny and all these people with their narrative. It's just making it a lot harder for pain patients who are legitimate and need their opioids to get the pain medication. So it's been really hard, but I'm here. I'm fighting back against this narrative and kind of trying to educate my colleagues in regards to this narrative. So it's been an interesting few years.
Right, but it's but there's a lot of money involved in this narrative because he's participated as an expert witness based on prescription opiates and addiction. So if he changes the narrative, then he's basically throwing his clients under the bus, and he's almost like contradicting what he said.
It's very
under oath.
Because it's very lucrative. I mean, they say I think he gets paid $725 an hour from what the law firms were paying him, which is very lucrative. So of course he's going to continue with that narrative because he's getting paid so much with this litigation. So it's crazy.
Well, it kind of picks up. As I stated before, I think before we started, we've been covering primarily from an economic lens, shareholder lens, opioid crisis for the better part of 3 years. So about your career, right? So you kind of came in at a perfect time. But one of the things that I constantly harp on and kind of get on my soapbox about, because even when we look at the wage stagnation, we're kind of in the midst of a labor revolt. But the largest labor revolt that's happening is in retail. And I think it's kind of on the nose that you bring up retail, because when we look at the largest effect on income, like not just income stagnation, but even degression, a stat that I kind of give out is what was pretty interesting. A. Philip Randolph, for those that aren't familiar, one of the first men to put together a black union, the Union of the Sleeping Brotherhood of the Sleeping Car Porters. Well, he was actually the first one, not Martin Luther King, to do the first march on Washington, but it came under threat to FDR. FDR, said, "Hey, I don't believe you." Said, "No problem. I got about 250,000 people ready to stand on your lawn picketing." And what they were marching for was $1 to $2, like a wage hike from $1 to $2. Interestingly enough, if you guys remember, I think it was around 2014, 2015, the fight for 15, where retail workers, largely McDonald's, Wendy's, KFC, came together. And they were fighting for $15, right? Well, if you convert $1 to $2 from 1933's dollars in, at that time, 2014, 2015 dollars, do you know what the amount was? $16.33. The exact same fight. 80 years prior. The exact same fight. So the reason I bring that up is because this is the same group of folks, in other words. It's the same sector of labor that continually gets downtrodden, picked upon, and really disseminated. When we are talking about these blanket policies that ultimately negatively impact our communities, and whether folks want to deny race is a factor, whether they want to just focus on class and not race, cool. I'm not one of those folks.
Me either.
I don't do the goofy stuff. But we all know, just even from a historical standpoint, certainly a statistical standpoint, that there's no coincidence that there's a certain demographic that continually finds themselves at the negative end of these blanket policies. So when we talk about the stigma that you were referring to and the retail, that kind of all sews it together, that this has not been a problem that has existed just in the last few years since opioids were created. This has been an issue, and we first saw the war on drugs under the first Bush, right? And clearly we didn't learn any lessons then, but this continues to rear its ugly head. So I think that is something worth mentioning because of the couple of points that you made, and I thought that those were very good points, and essentially worth echoing, just to kind of bring that history to really show that not only is it history, it's present as well. We're living in that same time, and sometimes I'm just kind of dumbfounded, like, wow, we're really doing this, huh? We're doing the same thing, huh?
Okay, so we're
over and over again.
So we're up on the 7:35 mark. So you can let me know when you have to go. But I guess I'm curious about what you think about the impact of the pandemic on these numbers on drug overdose deaths, if any. And
yeah, I think the pandemic has definitely exacerbated a lot of issues, and actually agree with what Kolodny was saying. Surprisingly, again, in regards to that, you have a pandemic, right? You have isolation. You have not being able to access treatments. So it's going to be hard, especially when you're falling into relapse again. So the COVID pandemic has definitely exacerbated the issue. It just came at the wrong time, because it's just like the drug overdose deaths are just getting worse and worse. So it's really sad that this what this pandemic has brought, not just COVID, but because of all the other issues that are happening because of this pandemic, drug overdose, mortality. It's been sad to see.
Hey, Dr. William, I'd like to get your perspective on this, because I think we generally agree that the COVID-19 pandemic worsened the whole drug abuse and drug poisoning of America. But I think it would maybe be helpful to get into the detail of that. One of the things I've noticed is early in the pandemic, there's a lot of fear, there's a lot of angst. And so you saw a lot of patients using telemedicine for no real traditional medical need, but to express their fears, to ask what's going on, to almost try to make sense of the uncertainty. And so when you introduce that uncertainty element to an already precarious situation where you're dealing with wage issues, exacerbated by race issues, exacerbated by subtle discrimination, whether you see that in the general society or in the clinical decision-making made when a patient appears in an ER. All of these are really multidimensional forms of subtle discrimination, almost micro-discrimination, that individually wouldn't really move the needle, but in tandem create a mountain of an effect. And what I've noticed really is that people became less able to handle their underemployment during the pandemic, less able to handle the social stress from their family, less able to handle certain things that make a person's life difficult in any other time, made it unbearable during that time. So if you look at it in that perspective, overdose or dependency or addiction is not one concrete act, but a very micro particular decision that takes place in an otherwise complex array of decisions. So I guess, Dr. William, from the pharmacist's perspective, was there anything that you noticed differently in patients requiring certain medications or asking for certain medications, certain nuanced differences or tendencies in patient behavior that you might have thought this might be due to the pandemic, or it might be due to the pandemic exposing something that was not as prevalent?
Yeah, that's a good question. I think in the hospital setting, I mean, currently not so much, but I think that hearing just some of my colleagues who are in like the retail space and who are in that space, I think that some of the things that you were speaking to, like how the COVID pandemic kind of brought about, certain things that, as far as all these different decisions and all these different things that are coming up, I think that some of my retail colleagues, I think, saw some of that during this pandemic, and I think that it kind of what you were talking about before. I think that it kind of exposes the narrative that Kolodny and all these people do, because we're kind of getting to the root causes of certain things, right? Instead of just looking at the end result of overdose mortality, we're peeling back the layers and understanding, okay, so this pandemic is bringing about certain things, economic issues and race issues and all these different things, especially within the pharmacy side. If we need certain medications for whatever condition we need. I think that this pandemic has really kind of peeled back the layers and kind of shown what exactly is going on as far as like the root causes of certain things. So I think that what you were saying before, I think you laid it out perfectly. Like, I think that it kind of exposes like this myopic like narrative of just okay, this causes this, instead of peeling back and understanding kind of the root causes of certain things.
Okay, but he also talked about less cross-border activity during the pandemic, which made it easier to ship fentanyl into the country. But he also talked mostly about heroin. He didn't talk about prescription opiates. He talked about heroin in connection with fentanyl. So I just want to get your perspective on that and go around the panel. Dr. William first.
Yeah, I think there's a lot of public health experts who kind of speculate about the heroin, because you have the black tar heroin on the west side versus the other forms of heroin. So now we're seeing heroin get out of the market. Now we're just seeing like illicit fentanyl in the market. Like now we're seeing like heroin markets being displaced completely, and now we're just seeing fentanyl. So if someone thinks they're getting heroin, it's all illicit fentanyl. Wow. And the crazy thing about it is that now it's going into the Western market. So now we're seeing places like was said in the interview, like California, like they're being hit hard with illicit fentanyl. So now it's kind of not only staying in like the eastern side, but now it's kind of all over the U.S. now, and it's displacing heroin markets, and now it's just like completely illicit fentanyl, which is another crazy aspect.
Yeah, I think there's a couple of things to that. So, Dr. William, you're completely right. The reason why, and this was actually predicted by the Department of Defense when they left Afghanistan, the cost of heroin is decidedly higher than the cost of fentanyl, because it requires a lot of farm labor to grow the poppy, to extract it, and to produce the heroin. With fentanyl, it's a purely synthetic component. So what happens is you don't have that labor cost, so the prices can go down. So now you're dealing with a greater high at a lower price. So if you want to deal with the supply side component of it, it's now at a lower price point. It can service a greater demand. But now what you're seeing is, because there's no longer that heroin that was being pushed by the Afghans and whatever was going on in that Central Asian region, you're starting to see a lot of diversity. So you're seeing fentanyl, methfentanyl. You're looking at heroin and fentanyl components. And what happens is, with these unique concoctions, the body of the person who's consuming those substances is not used to it. So you're developing various reactions to various mixtures of these supposed Norco laced with fentanyl, supposed Percocet laced with methfentanyl heroin. And so there's a wider variability in the drugs that are available that are purported to be opioids in a prescription pill type format. But what happens is, because there is such a diverse array of what's actually in it, from fentanyl, methfentanyl, opioid, heroin synthetics, you're getting a disparate range of responses. So a person who may be used to taking 50% heroin, 50% fentanyl concoction, all of a sudden is given a 90% fentanyl concoction, and the dealer, he or she may not know that, then that person whose body has been acclimated to that particular type of potency also now takes something even more potent. And so you start to see these diverse ranges of overdoses and reactions because there's now a greater variety of what's available on the illicit market.
You bring up a point, Dr. Joshi, that we
Start to interrupt, but I got
okay. Thank you for your time. Thank you for your time.
But thank you guys so much.
We hope to have you back on as well.
Yeah.
Definitely.
Thank you so much. Thank you.
Thank you guys so much.
Just to to your point, Dr. Joshi, we brought up this point. I think even a couple months back, maybe, and it kind of sounded counterintuitive, but for anyone that has known, especially when kind of came up during the quote unquote crack era, you saw functional, you saw functional drug addicts. You saw functional people going to work, living, raising families, but they were also addicts. And when you got to understand that concept of, because it seems counterintuitive, like, wait, you aren't in a dark alleyway, homeless and dirty and living in a sewer, because you're taking cocaine or because you're getting high on crack. And it kind of shatters that image of the type of life that one can live, also being addicted to illicit drugs. But then, two, it brings up the point that how can you have a decades-long drug addict? How can you have a drug addict that kind of lived beyond the first few hits, right? Because going back to, again, that image that kind of one. We used to call it one hit of the quitter. That meaning, that one high could be your last high. And that was largely pushed as far as drug education, especially to youth. But
I would say this, Mr. Mitchell, if I don't, I apologize for interrupting, but I just want to kind of point, I think this is very important. There's a difference between addicted and dependent, and there's a chasm between what the difference is. So there may be an individual who, for whatever reason, may choose to be dependent on a crack cocaine type substance, yet maintain a certain professional life, And so that person, as we understand it, may not be truly crack addicted, in the sense that you would look at somebody who is engaging in self-destructive behavior, but kind of just shows to you that there's a wide spectrum between what is a dependent patient versus what is an addicted patient, and the various different types of personification that can exist within that disease spectrum.
Well, I appreciate that. That's because, one, we certainly were not delving into that nuance. When you're engaging in that activity, you are stigmatized, even within the community, right? Inter-community stigmatization. But more to the point, the ability to be able to tell, which is what you were alluding to, that hey, if you're conditioned that you take a certain drug and the contents of that drug, and your body has been conditioned to take that drug, but all of a sudden, when the supply has changed, when the reliability of the manufacturing process has changed, and all of a sudden you OD, and especially for folks that understand or have family members or friends that understand that this is the person that takes drugs, right? This is even if they live kind of a double life, so to speak, but this is that side of life that eventually is going to catch up to them. And it's just kind of written off as, oh, well, it just caught up to them. Like, yeah, we kind of saw it coming. We knew it was eventuality, and we can't necessarily argue with the outcome, right? And it goes overlooked as well that, wait a minute, that's actually not what was happening here.
Yeah.
That although this person may have been drug dependent, as you pointed out, by choice, that clearly there's an issue with the supply and manufacture. And how many folks, and the reason I bring that up is because, hey, how many people are going to, I think, care enough to dive into that nuance? Especially,
well, I hope that the pandemic has taught us that there needs to be much more people, many more people, who care about this issue at hand, because it affects everybody. It's a fundamentally American problem, and for those who are not American, who come to this country, who become American, the problem becomes theirs as well. It's a fundamentally American problem, just as the issue of slavery, this is the issue of systemic racism. These are fundamentally American problems.
Well, I'm glad you pointed that out, because that is, that we can, that would be a whole other show.
Yeah.
Into diving into some of the reasons that it becomes a fundamentally American issue, such as the connection to family support systems, etc., where when folks that typically immigrate to the U.S. no longer have those systems in place, as one of the reasons that it, in my opinion, is a unique American issue. And then coupled with the fact that no other country health system is like the American health system. There's no other country on the face of the planet, literally zero, that compares with the American health system, even in cost, even in the way our processes and policies that support the healthcare system. So yeah, that's a whole, we can, we'll have to have you back on, in other words, just to dive into some of those things. But I just wanted to kind of point that out as well, that it's not simply, I don't think it's just even pointing a finger or simplifying it as pointing a finger of, oh, these are folks that kind of deserve that, right? These are folks that were either addicted or dependent, but they were taking drugs. These are just bad people. And they should have known what the consequences were, and they should have known what was coming, in other words. And taking that approach, in my opinion, allows this issue to continue to prevail. Because as long as folks continue to just point a finger and try to shrug off any accountability or, frankly, any empathy, then it will never actually get to a solve where we care enough to know that, hey, this is not just a simple OD, that no, there's a real problem here. And it's a problem that is not being fixed through policy, is actually being criminalized through policy, and is worsening the issue. And it's costing us even economically.
I'll put it to you this way. Propaganda has evolved from convincing people how to think a certain way to convincing people not to think at all. And if you look at the hollowness of this narrative that drugs are bad, that people who are dependent or people who are addicted are just fundamentally bad people, there is no basis for it. There's no basis for it clinically. There's no basis for it as we understand human nature, as we understand the pathophysiology of addiction. So from a medical standpoint, a moral standpoint, there's really no basis to think this way, yet we persist in thinking in this way. And that shows you the power of narratives in human nature. Think about this for a second, okay? Let's take the current president and the previous president. So take politics aside. The current president has a family member who's struggling with addiction, okay? We know who it is. We don't need to get into all that. The previous president also had a family member who was struggling with addiction as well. The substances were different. They're different family members. But if you look at that, you think about that for an issue, just how intimate the issue of addiction and dependency and substance use is in America, and how we try to just cover it up. Yet it's everywhere. Even at the highest levels of political office, it is speaking to us right in front of our faces. Yet we're not listening because we're blinded by the narrative the hollow narrative that simply tells us something that we know to be fundamentally wrong, yet intuitively we succumb to this story that is just leading us astray. And as you'd mentioned, the consequences are financial, economic, social, and in many ways is exacerbating the divides that we see, like along class, like along race, like along gender. You know, it was very interesting. There was a discussion about abortion, and it makes sense. The issue about abortion. Now, is the abortion a fundamentally female issue, or is it a issue only of females, POC, people of color? And if you think about that, it sounds so irrational to think in that way because it should affect all women and all women should care. But when you start to dissect it through and you look at the narratives around abortion, it's clearly targeted towards POC women. That flawed narrative is leading to these laws and these nonsensical debates that we're having around the issue. Now, whether you're for or against abortion, you have to at least acknowledge that we don't address the issue in the right manner. Same thing with addiction, dependency, and substance use. Whether you're for or against restricting or providing access, you have to acknowledge that the way we narrate the story of dependency, addiction, and use in America is leading us to these false narratives and creating these false policies.
Right, but in terms of on the issue of narratives, I think for people in the audience and also for a lot of people in pain who are and doctors and who are frustrated with the narrative coming from Mr. Kolodny, that is almost like he I won't say he has to, but it seems like if he doesn't stick to the narrative of prescription opiates and addiction, those two words, then you also have, because I think this opioid litigation and this opiate hoax, I won't say opiate hoax, but prescription opiate litigation, this litigation seems to be underpinned by his narrative. You got 32 billion of opiate settlements from Johnson & Johnson, McKesson, Cardinal Health, AmerisourceBergen, Mallinckrodt, and
Teva Pharmaceuticals,
and Purdue Pharma. And he's in all the state AGs and all the legal documents repeats this narrative that it was the opiate manufacturers that duped the doctors into prescribing opiates, and they didn't know what they were prescribing, and so on and so forth. And they had marketing efforts that were not true to how the product worked. And then you had prescription opiates and people became addicted. If he changes that narrative, then you would think that the defendants would also watch those interviews and could use his words against him. If he's an expert witness and then he's telling you it's not coming from prescription opiates and it's not coming from opiate addicted people, then the whole lawsuits could be almost could be thrown out or could be dismissed.
Yeah.
And all these, and I understand that also it has affected some of the CDC guidelines, this narrative of prescription opiates and addiction.
Yeah,
if he changes the narrative, and it could change everything as far as the CDC guidelines and maybe even some of the lawsuits. Because I'm sure the defendants could also use your expert witness's own words against them.
Yeah, I think the crime is in the simplification. So when you simplify the CDC guidelines to law, where you say, if you make this decision based off a guideline, you're committing a crime. It's a deliberate manipulation of a complex set of rules. If you look at the CDC guidelines, the CDC themselves have acknowledged that there is a potential for misuse. Insurance companies and the Department of Justice have acknowledged that they have used the CDC guidelines to prosecute physicians, to engage in criminal investigations against pharmaceutical companies, healthcare providers. So the crime comes into simplification. So for people like Dr. Kolodny, it becomes very difficult to believe that they think it's this simple. Given all the evidence, given all the data, it strains credulity to think that they believe truly that the opiate epidemic, that the addiction overdose epidemic can really be simplified into these convenient narratives. And you often kind of wonder why they continue to espouse these simplified narratives. Even if they're kind of moving in the right direction, we know so much about addiction, dependency, and substance use that we need to start going away from these convenient simplifications. But like you had mentioned, tort law and tort litigation is such a big elephant in this country, and there's so much money that they're incentivized to simplify because the liability comes from the simplification. The crime is in the simplification, so they predispose to look in that manner.
But also to continue to simplify even after you have additional data.
Yeah.
When you have drug overdose deaths continue to rise as opiate prescriptions have been cut dramatically.
Yeah.
And to continue with the narrative. That's what I'm saying.
Completely agree, yeah.
Because there's so much money riding on it.
Well,
and so much credibility may be riding on it.
Well, I think too, it's important to actually dive into some of those actual numbers, so folks can really contextualize what's being discussed, right? Because over the same time period, from 2015 to present, opioid prescriptions have dropped 60%. 60%. I'll say significant number. Huge. You have dropped out a huge treatment resource out of the market altogether. There's only a handful of manufacturers left that will even entertain manufacturing opioids. So on one end, I think it's important to note that while 60% has dropped out, that we've watched the OD deaths increase over that same time period, but also the fact that what is the incentivization there? That you still have DEA, you still have tracking ability on a state level, on a federal level. Where is the money flowing into? And I think that that's the question that incentivizes this continued criminalization of physicians, of even, albeit, biopharma companies, although, those are the last folks that probably need any defending from the public, right? But, unfortunately, you have to look at what's right is right? That who's standing on a side, and to me, a clear line in the sand has been drawn. Like, for example, we talk about Endo a lot on this show. Endo was one of the first, and actually the only biopharma company that took their opioid drug, Aparna, off the shelves before litigation started. So when they took it off the shelf in 2017. In other words, they've continually get swept up in this criminalization, and I think the question that has to be asked is who's benefiting from this continued oversimplification? If the drug manufacturers have complied really since 2019, 2020, everyone has taken off their opioid drugs or significantly cut the supply, yet the crackdowns by the DEA, ATF, and the other alphabet law enforcement agencies continue to increase. Who is benefiting? Who is materially benefiting? We know it's not the patients, because we're reading about their deaths in the newspaper every day. We know that it's not the we know it's not even the folks that choose to be dependent, even versus addicts, right? Because if I'm a drug dealer, I would be concerned about my supply, because just like any other business, whether illicit or otherwise, the way that you continue to be successful in business is to have repeat customers. So if my customers keep dropping dead, then that means I got to constantly find new customers. So even as a drug dealer, as counterintuitive as that sounds, I don't necessarily materially benefit in the same way if I want to continue to get repeat customers. So the question, again, just kind of framing it, who is materially benefiting here from this continued criminalization of opioids?
Yeah.
Well, I mean, on a 20,000 foot level, I mean, people I've spoken to say it's really wealthy upper middle class and wealthy people whose children have maybe become addicted or OD'd on opiates, and they want on maybe heroin or something else, and want to blame the opiate manufacturer because it's maybe more. It's less embarrassing to say my son or daughter OD'd on opiates or was addicted to opiates after being prescribed opiates and then turned to heroin or heroin laced with fentanyl than to say my son or daughter's a heroin addict. And, in the case of, in the case of Opana, Opana actually had medicinal purposes and it was effective for people with pain and more effective in some ways than maybe Lidoderm or Vicodin or OxyContin or Percocet or hydrocodone. But there were people who were crushing it and snorting it and also cooking it and boiling it down and taking it intravenously and getting sick from it. And they wanted to blame the manufacturer because it wasn't crush-proof enough.
Yeah.
You follow what I'm saying? So it's almost like there's no responsibility for people who are taking opiates and maybe become addicted to opiates and maybe opiates that weren't even prescribed to them. That doesn't, crushing Opana doesn't sound like a pain patient. It sounds like a drug, someone who wants to do drugs. Cooking Opana, if you're in pain, you don't have time to cook Opana and take it intravenously. You know what I'm saying? That sounds like a drug addict. It doesn't sound like that sounds like drug seeking behavior. It doesn't sound like a pain patient. And so the people who are for some reason crushing Opana and snorting it or cooking Opana and taking it intravenously are not held accountable in the same way that people who were taking crack in the 80s or 90s. So, and that seemed to be and that's not the narrative anybody's talking about. We can get into that deeper at some other point, but I think you bring up a point. I think it's nobody talking about the pink elephant in the room. That when as an African American, you see the government getting its standard up over drug addiction, and they're going to decriminalize it. You know who's taking it.
Yeah,
you know what I'm saying. But anyway, as far as another thing, Mr. Kolodny said that he doesn't have any hope. There's no hope right now. And that's different now than what he was saying a few years ago, that if you basically reduce prescription opiates, you can solve the opiate epidemic. Now he's saying after reducing prescription opiates sharply, now there's no hope because people still ODing, drug overdose deaths continue to rise. Now it has no hope.
Yeah.
I was curious what you guys thought about that.
Well, I think that it just kind of shows like the fallacies that happen when you simplify a narrative. And so he depended so much on his claim to fame of reducing prescription opioids as the way to solve the opiate epidemic. And, it's hard to believe that he actually believed that at the time. But suppose, for example, that he actually truly believed that's how to solve the opiate epidemic. That is really just that simple. Now that has proven not to be true, he almost has to acknowledge that it was not the right way to think about the opiate epidemic. And as you mentioned, there's a lot of legal liability, a lot of financial gain that he obtained in perpetuating that narrative. So it's almost
and trial gains for trial lawyers who are making about $2 billion, and also for the states who get gone about $30 billion.
What's interesting is I actually submitted an amicus brief for the Purdue Pharma Chapter 11, and I sat in on one of the hearings. There was nothing about the patients. And I wrote a brief on behalf of my patients who asked me to write for them because they were plaintiffs in the lawsuit. They still haven't received anything from it. They even told me, please write something so that people will remember that there are patients involved in this lawsuit. That lawsuit had nothing to do with patients. It was really about one law firm extracting capital from another company and depositing it somewhere else. It was a series of lawyers trying to redistribute wealth by moralizing a medical condition that they had no idea about. There was no discussion about the effects of the opiate epidemic. None. The judge had to, at some point in the hearing, actually mention, let's not forget what the issue at hand is.
Right.
And so what that really demonstrates that tort litigation has grown so large that it has surpassed even its own purpose, its own intended use. And that was to solve issues of liability. Yet the claim of liability is no longer represented in the problem itself. And that's what happens when you start to moralize laws, moralize healthcare policy through misinterpretation of healthcare laws, and justify those misinterpretations with convenient narratives by individuals like Dr. Kolodny. And when he says things like, I have no hope, I would disagree. I would say that you should always be most hopeful when times are most bleak. And if you look at what the pandemic has done, it has raised issues on healthcare inequities, the philosophy of medicine, how looking at medicine through just data and technology will never fully address the patient. And those types of new ways of thinking will help to improve how we approach addiction, dependency, because they were never really technical issues. They were never really scientific issues. They were ethical and moral issues that were addressed by the art of medicine, not this pervasive science and technology of medicine.
Right, but also I think it also shows that it can have some very influential individuals, how they can control the narrative, how they can shape the behavior of politicians and maybe consultants. If you have some influential individuals who kids may have become addicted to opiates or OD, they can pick up the phone and call their congressman or what have you. But similarly, in terms of Dr. Kolodny, for years he's been saying the earth is flat. Now when he found out he's round, he still wants to have a platform.
Yeah, it's tough.
But as far as Mr. Mitchell, as far as the no hope.
I was just going to say that I think, honestly, Dr. Kolodny is a cog in the wheel. He's picking up a paycheck. In fact, our chat has been lighting him up, I should say. He made, apparently, allegedly made about $500,000 from J&J trial alone. A lot of shots being fired at Dr. Kolodny, and rightfully so, because when you put yourself on a platform, you are also accepting the responsibility of what comes along with that platform. So, in other words,
ideally,
correct. And I think he's just the chosen one, right? That he agreed that okay, I'll be the puppet. Let me open up my backside, and you can shove your hand as far up there as you need to, as long as the check's clear. And I think that's really.
This is a PG. This is a PG rated show.
Speaking plain terms on this show, and this is our toned down version for you. Just kind of call it what it is. And is Dr. Kolodny the end all be all? No, but does he represent the politicization of what has become a moral issue, which, to your point, which you've been making this entire time, Dr. Joshi, is that this should not be a moral issue. It's like, one, our laws, our judiciary and judicial system are not structured on morality. Like, we're not in a position to say with any sort of finality, is this good or is this bad? We can say something, murder your neighbor, is that bad? Yes, you murdered your neighbor. Well, the neighbor was a pedophile. Okay, well, I mean, it's justified. So in other words, because morality has so much gray and it is based around social norms, what is the social norm for the time? It makes it challenging to say definitively, well, this is good, this is bad, this is what should happen, what shouldn't happen, etc. But when we focus on the medicinal, when we focus on the things that have more defined left and right parameters, it makes judgment a bit easier. It makes our decision making a bit easier to say, well, this is, even if this is a bad person or a person that commits things that are outside of the social norm, should this person go without treatment? Should this person go without access to a medical condition that they suffer from? And that's really what the question becomes. And since this has been politicized, Dr. Kolodny, in my eyes, just represents the person that decided to stand in the line of fire for a paycheck. He's a talking puppet, and it's not really him that is driving it. It's really the administration, in my opinion. When you have, when you look at the money trigger, and again, because we have seen this in history, we've seen that we are the only country that the next three countries, in terms of the amount that we spend on defense contracting, well, guess what falls under the DoD? Drugs.
Yeah.
And you cannot just take a $80 billion market out of GDP without replacing it and expecting the same outcome. So even from an economic perspective, we see that there are more hands in this pot. In other words, we see state hands in this pot by way of state AGs. We've pointed out on the show several times because New York State AG Letitia James kind of really led the charge for the rest of the state AGs, even fighting against a global settlement. New York recently, well, it's been about 2 months now, New York recently settled with Indo, but got a global, but was a part of the global settlement. And where did that money go? Well, it didn't go into the patient's hands. It didn't go into the hands of the families that have suffered. In fact, New York AG right now is on a statewide tour handing out bags of actual cash, trying to, frankly, buy a vote. Because, for those that don't know, New York politics in New York City vary differently than the rest of New York State. So just because you're popular in New York City doesn't mean that you have the same, gravitas in the rest of the state. So this is our way of, building up that gravitas by handing out bags of cash, because frankly, there was no mechanism that was getting the money into the families' hands that have actually suffered, into people's hands that have suffered over the last 4 to 5 years because manufacturers have cut the global supply by 60%. So, in other words, to your point, this was never about the patients. This was always about the politicizing, in my opinion, the politicizing of an economic opportunity. What is a way that we can write a blank check in order to continue funding and justifying why we spend so much money on law enforcement, on DoD contracting? So this is just another thing that has allowed a blank check to be cut, because the narrative, if you stand and say, well, we actually don't have an opioid crisis. Whoa, wait a minute. We're going to put you on the back burner. We're going to put you under the rug. Right? Yeah. Because the narrative has to be, thoughts and prayers, because it's an opioid crisis. For the first time, white people are dying at a faster rate than they're being born. So our population is decreasing. So we have to, thoughts and prayers. We have to, show sympathy and empathy for that. And we have to approach this in the right way. Right? So let's write a blank check. Let's give ATF something to do. Let's give FBI something to do. Let's give DEA something to do. We have to justify the fact that, even Obama's policies, when federal policing was only about a $200 million contract, that we have to justify the fact that he 10x'd it to $20 billion. Yeah. So we have to justify that we defunded education, that we defunded Social Security, that we... So the way to justify that is, hey, we got an opioid crisis. We got a drug problem. Yeah. And, we got to, even your average police officer, your average beat cop, went from 50K to now 120K. Yeah. Because, you have to deal with this opioid crisis. And, these opioid addicts are erratic, and they're dangerous, and at any moment, they could shoot a gun, and we got to justify their salaries because they have to deal with that danger on a day-to-day basis. So, in my opinion, even the idea of saying, well, it's hopeless, I don't really have hope, is just a continuation of that narrative that the puppet master that has his hand or collective hands up Dr. Kolodny's backside is telling them to say, because as long as there is hopelessness, what does that cause folks to do? To go right back to the same systems that you have already criminalized, that you have already put federal minimum mandates by this very president that's in office when he did it back in 1990 and then again in 95. So this is the same administration that criminalized the very conversation that we're having right now. And
Mr. Mitchell, unfortunately, I have to get going right now, though. So, but please don't. Thank you so much. I really appreciated joining this conversation. I hope that we can stay in touch, and please just let me know if there's anything else that you guys need from me. But I appreciate the conversation, and thank you, guys. Appreciate it.
Absolutely. Appreciate having you, Dr. Joshi. Take care.
Thank you. Okay. So you were saying?
No, I mean, that was pretty much my, wrap up on the question of hope is just, the idea and putting out there, kind of flourishing that narrative that there is almost nothing to live for. Because that's what you're really saying when you're saying there is no hope. It's hopeless.
But that's what he's saying. But we don't have to say that.
No, because that's what I'm pointing out. That by him saying that is the thing that will keep folks in a hole. In other words, by continuing to put that out there, the fact that even economically, we talk about this endlessly on the show, that the economic outlook almost aligns with Dr. Kolodny's words, right? So it's not a far stretch to say, well, it's kind of hopeless, right?
Well, we could have.
That's pumping into an economy and now finally tapering off, and you have wage stagnation, and you have a inflation rate near 7% in just a 3-month period alone. Groceries going up, rent going up, mortgages going up. So in other words, what are folks going to continue to turn to? And it just becomes a cycle. In other words, an endless cycle to be able to continue funding government activities in order to justify an overbloated DOD and law enforcement federal allocation. So this is and to me, that was the point. That was the point of him saying that it's hopeless. And they can talk through him or kind of speak through him because he has put himself as that spokesperson.
Okay. So we have another person join the conversation. Tracy Chalifo. So we'll wait for her in a second. But again, I think all right, Tracy. Hi, how are you? Okay, could you introduce yourself and tell us a little bit about your background? All right, Tracy.
Might have a. Can you hear us, Tracy? Okay.
Can you hear us?
Okay, perfect.
Okay, could you introduce yourself and tell us a little bit about your background? Yeah. Okay. So anyway, so as far as as far as hope, I mean, maybe I think the best thing would have been to do was to have someone who had you could have maybe addressed some of these issues before it got to as far as the opioid epidemic is concerned. But the other point he made was that he kind of blamed Biden. He said Biden had sort of inept. Biden called Biden inept, and he called he kind of blamed some of the rising opiate epidemic on the fact that Biden hasn't really acted. Yeah, I think you kind of got into here by accident, but I think you should be on the as one of the in the audience. I think somebody sent you the link for the be on the chat by accident. Yeah, it's so fine. But Torian, go ahead. Go ahead. So
well, yeah, just
but he trying to try to blame Biden. So it's kind of like counterintuitive. If you're an expert witness in legal cases where people are suing opiate manufacturers for $30 billion and plus, why would you need to go to Biden to get funding for treatment prevention if that was supposed to be used for treatment prevention? And if we should get money from Biden for treatment prevention, why are we suing the opiate manufacturer? Maybe we shouldn't be suing them at all. Maybe we should just go to the government to begin with to deal with a public policy issue, not a legal issue. That seems to be what he's saying in a roundabout way. Would you agree with that? Torian.
Oh, yeah, I thought you were asking Tracy that. So I would agree with that, but also I would be interested in hearing a little bit of, I guess, Tracy's experience. You said you've been 2 years without access to pain medication. So since, I don't know what state or can you hear us, Tracy?
Tracy, can you hear us? Tracy, can you hear us? Okay, sorry about that. But yeah, so so as far as
what state are you in, Tracy? Okay, Idaho. Do you know the I've been to Idaho actually.
Well, yeah. You're on the big stage today.
Right. So as far as the state AG's participation in a global settlement, what has your experience been? Has the state AG reached out to folks like yourself? Because as you said, you've been 2 years without pain medication. So has there been any recourse for you specifically, or even people like you, especially from the state AG's office, as they've participated in this global settlement? Have you been able to get resources since the global settlement? Mm. Mm-hmm. Wow, really? Wow.
Right, I think it's an important point to make because I think a lot of people online today were asking about what do they do? Where do we go from here? And that I think it's nuanced, but before we get to the fact that there needs to be more access to pain medication, I think we have to break the narrative that that prescription opiates cause the opiate crisis. We have to break that narrative first, and then you can get to the point where where do we go legally as far as this opioid litigation, and where do you go as far as the CDC is concerned in terms of trying to make opiates more available from a prescription standpoint? Would you agree with that, Torian?
Well, I think too, yes, to your point, yeah, that would be nice, but what do folks like yourself and others do while that narrative is being changed, if it ever changes? Because, a part of what we're doing and saying is a little optimistic, right? Like we're hoping that narrative will change. We're hoping folks like yourself, Tracy, that were patients and experiencing doctors leaving. I mean, to me, that's crazy to even wean a patient off in 45 days. Hey, even if you were an actual drug addict, you wouldn't be weaned off in 45 days. So how is it that that is deemed acceptable, like medically acceptable, for an actual patient that is experiencing breakthrough pain? Like, to me, so the question for me is, what are the resources for folks like yourself until the narrative changes? It can't just go, because this could be another, who knows, right? It could be another few years. It could be another, it could be another couple days. The fact that we don't know is the problem. That there is no definitive timeline here, and there hasn't been any definitive resources. So Idaho did participate within the global settlement. So, to your knowledge, there hasn't been any resources to support physicians getting, at least offering replacements. Okay. Mm.
Wow. Well,
Wow.
it's
Wow.
fun. It's interesting you said it because what came out of the one of the recent trials was that some of the consultants or some of the expert witnesses were telling their clients, telling the plaintiffs that about 25%, almost 25% of people who take prescription opiates become addicted, and that's just not the case. It's more like 5% or less. So if you take prescription opiates and you do it and you do it, the right way and it's prescribed the right way, you can treat pain and not become addicted. And so one of the things that I think some of the people are recommending is Suboxone. For some reason now we're hearing from actually a person who takes Suboxone that is more addictive than opiates, which is something that people need to know about. That what the people who's experienced with these drugs has a totally different narrative, and you can't get to the right situation as far as maybe making prescription opiates more available until you actually diagnose the problem and then address it after you diagnose it the right way. And so this is very interesting to you to say that as far as your experience with Suboxone.
Mm. Oh, this and I wanted to give an opportunity. Did you have any questions by chance, Tracy? Or
Right, right. We do. Well, really, we do this for you. We really do this for you. We try to serve as a conduit for people who want to know about, for people who want access to, to more pain medicine because as prescriptions have fallen, people have less access to opiates, and at some point, we're all going to be in pain. Believe me, and we all want to have the proper treatment and the proper diagnosis and proper medication. We will all be in pain someday. Believe me.
exactly.
And so we all have a vested interest in this. And
Mm.
wow,
Um, Hey, right.
right, right. So what we've been fighting against. So we have invested in a few companies who have been hit with lawsuits from opiate lawsuits, and we're saying these lawsuits are way overblown, and they should have if the state AGs, the narrative is that they want to get money for treatment and prevention. If the state AGs really want to get money for treatment and prevention, they would have settled this years ago and put money into the communities for treatment and prevention. And so now you have the fact pattern is that you had a global settlement, and this summer, which almost like 4 years after Trump threw down the gauntlet about we need to do something about this opiate epidemic, and now you have some state AGs giving money to treatment centers. This is almost 4 years after the fact. You know what I'm saying? They could have done this years ago. And we don't know, when they say give money to treatment centers, we don't know how effective it is. We don't know where the money's going, or the outcomes from the treatment centers and from patients like yourself who need access to treatment prevention. What type of treatment prevention are you getting? Suboxone obviously not working. You know what I'm saying? And so only people who really standing up for patients and standing up for people in pain are activists. Some of the activists, some of the lawyers, and the judges. The judges are standing up for patients and hey, knock it off. Knock it off. Prescription opiates have a place in society, and they are very effective for people if prescribed properly and taken properly. And they threw down a gauntlet and they said, knock it off. But you still haven't had gone from these legal cases and talking about it to actually action with the Health and Human Services Department or the CDC, and CDC is under the Health and Human Services Department, and the person who runs that is a guy named Becerra, who used to be the state AG of California before he joined the Biden administration. So he knows what we're talking about, because the judge in California just said you can't hold these companies liable for an opiate crisis. And there's no proof that doctors were inappropriately prescribing opiates. There's no proof. It's just a narrative. There's no proof behind it. So that's what we're trying to do, is really take it from where do we go from talking about it and making an issue for the public. Because it's not going to come from the corporate media. It's not going to come from these consultants. It's not going to come from these state AGs. It's got to come from people, concerned citizens, activists, and people, like I said, Trump and GE, who want to get information out there. And the two doctors who were on here earlier, who spent their time trying to educate us on this. So I'm glad you brought that up. But I don't know how to even get information from these treatment centers about what's being done, how much money they have, and where the money's going. And so while you don't have access to opiates, you have New York City now has a safe space for people to take illegal drugs. So you can have access to illegal drugs, right? like heroin and cocaine that can be administered. It can be administered and supervised by the government, but you don't have access to
legal
FDA approved drugs that are known to be effective. They've been prescribed by a doctor. You don't have access to it. And it seems to be a disconnect. And this is one of the reasons, one of the main reasons I did not want President Biden to become president. One of the reasons I wanted Trump to get reelected was because he was taking a stand on these issues. People may not like him in a lot of ways, but we always know where he stood, and he always made decisions based on information. He was given information that drug overdose deaths were rising in conjunction with a proliferation of prescription opiates. And he said, we're going to cut the prescription and let's see what happens. And then he actually settled with Purdue Pharma and said, this is going on long enough. We need money for treatment prevention. Got $4.5 billion from Purdue Pharma, a total $8 billion deal, $4.5 billion in cash. Said, we need to get money into these communities right now for treatment prevention. And you have state AGs who didn't like the deal. You have state AG in Massachusetts and state AG in New York who were complaining that they didn't go after the Sacklers who owned Purdue Pharma, the entire wealth. They had like maybe $13 billion in wealth. Only got $4.5 billion, and they didn't hold the Sacklers accountable. They wanted civil charges against them. They wanted to admit wrongdoing. And Trump and his DOJ at the time said, knock it off. We need money for treatment and prevention. We can't be in court for a decade. This is about people and about trying to stem this opiate crisis the best way we can. And when we put money into this community, if that doesn't work, we'll try something else. That's why I did not want President Biden to get elected, because now you have nobody at the wheel. It's a rudderless process. You want the state AGs running amok, suing people, putting out press releases, and using these opiate litigation for their own personal gain and for their own publicity, to run for high offices and to pad their careers. You have consultants like Dr. Kolodny, who was saying that it was prescription opiates that were making people addicted, and pain patients became addicted, and that caused the opiate epidemic, which is pure folly. And you still have this guy giving speeches and giving interviews. You have the corporate media still giving this guy a platform. So it's a rudderless process, and nobody's in charge. And this is why I did not want Biden to be president. Trump got reelected. He would tell these state AGs, get this deal done now. We want a global settlement right now, or we can find somebody else to do it. If you can't do your job, we'll find somebody else to do it for you. And so now we don't have a strong man. We don't have a strong man in office to make these decisions. Only the strong men are these activists who are out on the street and in these communities trying to get treatment for patients in pain, and try and get them access to opiates as appropriately prescribed. You have people like us who are trying to give a platform to people and get the information out here, get the real facts out here, and trying to find ways to move forward. And they're listening to us. You have the president on Twitter you have Biden on Twitter talking about the drug overdose deaths he's concerned about. You have the vice president on Twitter. You have Michael Bloomberg, Bernie Sanders on Twitter with us. We're on Twitter. They're on Twitter too. But they can make policy. They can make decisions.
Look, right? Why are you on Twitter? Right. You should be making policies, not being on social media.
We don't need you on Twitter.
We need you making policies. Well, Tracy, we empathize with your situation. We appreciate you calling in. We appreciate you watching. We do hope that some solution will come rather sooner than later. And I wish we could offer something better than words, frankly, and offer some tangible solutions. But we appreciate your contribution, Tracy.
So people in the audience, go ahead and shoot your questions to us. And to the extent we can answer them, we will. And to the extent that we need follow-up from the two doctors who were here, or some of the people who are experts in pain management, and some of the activists, we'll make sure you get the information to you. But people who have questions, go ahead and ask questions. You have any more questions, Tracy?
Well, thanks again, Tracy. We appreciate you joining us.
Okay. So he also talked about Dr. Kolodny also talked about again, more outpatient treatment, more funding for treatment prevention, which I guess maybe somehow would line his pockets, or some was that your interpretation?
Well, I think so. That he, as I've already stated, that he's just a puppet. I think he's saying what he's allowed to say, what he has room enough to say. He's not really offering any nuance, and that's the whole gag, is that there isn't nuance, that there is a blanket stigmatization, and that's how he makes his money, is through said stigmatization. If he wants to keep the checks rolling, he's going to continue saying what he is deemed permissible to say. Just as a quick aside, I've actually been going through the chat. So I've been trying, just to let some of the folks know, like Fun Chef Chick, hard to hear, Mary Wiley or Willie. Hopefully I'm not chopping up you guys' names too badly. Emma, some of the folks that have been in our chat since we first began. I've been trying to get some of the questions answered through our normal discourse. But they've been lighting up the chat. I'm hanging out with you, Tracy. Yeah. All right. I look like Stock Exchange got booted off, and I'm hanging out with you. So I guess you'll be my podcast buddy for the night. Maybe I think he meant to close you out. Closed himself out. I think so, but listen, we're not corporate media, so these things happen. You guys got to bear with us. we don't have the unfortunately we don't have the fancy equipment and all of that fun stuff. So these things happen, but we're just gonna keep it. We're gonna keep it going as if you're him. So we did. I don't know if you joined some of the folks in the chat, but there's a lot of. I've been trying to keep up. Some of you guys have been typing faster than I can read and listen at the same time. But some of the questions have been primarily as to why are people still listening to Dr. Kolodny? He's a fraud. Some folks have put his income as a consultant out there. I gave acknowledgement to that $500,000 in the J&J trial alone. I don't know who wrote this, if this was a part of Fun Chef Chicks. Said, in my opinion, Kolodny is largely responsible for today's dysfunctional response to drug overdose deaths by placing blame on prescription opioid for years. In 2017 in California, the chief of SUD compliance at California Department of Healthcare Services, so I guess decided to join us again.
Yeah, I did.
She continues on. Jim Wood had completely bought into Kolodny's opioid narrative, ignoring the coming wave of illicit substances. Tom Hayashi, or maybe that's the gentleman that wrote this, was Tom Hayashi. I don't know if some of these folks are still listening. I wanted to at least get some of the questions answered or addressed and talk about some of the statements while they were still on. So hopefully you folks are still with us that contributed to the chat. But they kind of going back to that narrative that Dr. Kolodny, they kind of place a lot of the public perception on Dr. Kolodny's shoulders. And while I do empathize with that, I got to push back a little bit. As I've stated before, to me, he's just a cog in the wheel. Hopefully folks can see that while when we kind of look back in history books, you will find instances where it is a handful, 1, 2, 3, 4 very influential individuals, right, that have kind of changed a course of society. Is Dr. Kolodny one of those forces? And in my opinion, I don't believe so. I don't think he possesses that much power. I think he is simply the puppet that as for whatever reason, there will always be people willing to sell their souls, right? Regardless of the consequence, as long as they feel financially safe and secure, they will, sell their mothers. We know that people, those folks exist, right? But why Dr. Kolodny out of that list of people that were probably champing at the bit to become the next puppet on this game show, what it feels like at times? I can't say why Dr. Kolodny out of the folks, right? I don't know. Maybe he was working his 7 habits of successful people and willed it into existence. I don't know.
Okay.
I don't believe that he is navigating the entire course, right? There's too many hands in this pot, as I've alluded to before. When we follow the money trail, who is materially benefiting from this? Alphabet agencies of enforcement are benefiting from this. DEA, ATF, local law enforcement is materially benefiting from this narrative being pushed. Lawyers are materially benefiting from this, even as Dr. Joshi stated that he sat in the courtroom with on one of Purdue Pharma's cases, and even the judge had to remind the lawyers what this was about. That it's not simply law firms. This is people, real folks that do not have the capital, real folks that do not have the resources, certainly the power to pull an entire community out of this this condition. So, like in other words, when we look at the 2.1 or 2.3 billion dollars that law firms have gained from this process, they have a direct incentive to continue this narrative. They want to continue going to court. They hope these things continue to get continuances and delays. They want to see state AGs standing on soapboxes saying that, 26 billion isn't enough. Let's go for 100 billion. Let's go for 500 billion. Because it sounds good, although it's realistic. You have a company right now, Endo being one of the companies. Can you imagine that the lawyers have literally made, one law firm has made more money through this global settlement than the entire market cap of a drug manufacturer? And can you think about that for a moment? That one law firm has made more money than the entire market cap of one of the drug manufacturers that was being sued in the global settlement. What that market cap, Endo's market cap, $1.2 billion. They're a whole company. And they took Aparna off the shelves in 2017, and you have a law firm that's made $2.1 billion. Does anyone believe that they have an incentive to see this continue going?
So we got about 10 minutes left, guys. So you get your questions in. We have one more question calling in, Torian.
Oh, okay. Yeah, bring them on if you can. Hopefully you don't boot yourself off.
You're telling me. Let's see. Okay.
Oh, it's our friend J Rod.
Okay, J Rod, the messenger.
Good. How you been, sir?
Okay, we got 10 minutes. We got 10 minutes, J Rod.
Okay,
what's your question?
Hey, this gonna be quick. I listened to a lot of it, and my thing is this: as a veteran, I'm in constant pain. And when I had my shoulder surgery, they gave me opiates, but I had an allergic reaction to it, so I had to stop it. And my experience of seeing opiate use is that you have people that need it, you have people that use it for recreational, and you have people that have become dependent on it. Now, out of those three, you can't distinguish which is which, because if the doctor cuts back on the prescription, what's going to happen? They're going to go to the street. And when they go to the street, ain't no telling what they're going to get. And what they're going to get is going to be the fentanyl. And so the fentanyl is much cheaper and much easier to get than the opiates from the prescription of the doctor. So if you're getting the prescription from the doctor and you're using it accordingly and don't abuse it, you're going to be good. But the problem is when the doctor tried to wean you off of it, and that person is constant in pain, and that doctor have a disbelief, maybe this person not in pain, and maybe trying to play the system.
Right.
And that could be the problem.
So what's your question?
So my question is, how do you distinguish that of the three, which is needed, which is for recreational, and which is dependent? How can you determine?
I guess that's up to a doctor to determine, but you're right. There's some people who are gaming the system and they're making it bad for everybody else. I'm not sure how a doctor makes a distinction between someone who legitimately needs opiates and someone who is, pretending to be in pain but wants access to it. I don't know how a doctor does that, but that's it. I
think it would be a great follow-up question for both Dr. Amarquaye and Dr. Joshi. We'll actually post that question, but really quickly too, to add to your point, And I think it's a point worth noting that J-Rod brought up, the fact that you're a veteran. I'm a veteran myself as well, but veterans in 2020, so according to one study, I believe, Truth Out, publicized the study that found that 57% of over 2,800 military veterans who died of overdose or suicide had a prescription to painkillers that was cut off by their doctors. And I'm reading verbatim from that study. We, I think us in the veteran community are well aware, you're only one touch away from someone, if not yourself, that is either dealing with pain, PTSD, or effects of being a veteran, being at one point active duty as well. So this impacts the veteran community, I think, at a significant degree that goes to your point about how do you tell the difference, right, between drug seekers, those that legitimately have pain issues or breakthrough pain, need the drugs, and those that are gaming the system. And, as you stated earlier, we all know, folks, that there's going to be some percentage that are gaming the system. But when we can see that 60% of the global opioid supply has been cut, and yet overdose deaths still increase, to me, that says that there are a lot more legitimate people that are in actual pain, that were real patients at some point, versus the handful of folks in the aggregate number that's trying to game the system. It's just like every year we hear about these Medicaid frauds, right? It's like, you're hearing about $100 million, $200 million Medicaid fraud. It's just like, holy crap, like how where are these people coming from? Like, how do you get these? And then you see, a dozen or 2 dozen people, but Medicaid is still here. It doesn't negate the people that need Medicaid. It doesn't all of a sudden rule out the use for Medicaid. It's the same thing, same logic here, that yes, there's going to be some handful of folks, and those are the folks that absolutely need to be cracked down on. Those are the folks that absolutely need to be in prison. Those are the folks that absolutely need to be criminalized. But for the folks that are in true pain, that truly need it, these are the folks that the access should be there. If you're going to take away a treatment option, you have to replace it with another treatment option. And I think that that's the largest issue that we're facing with even folks like Tracy. 2 years, like 2 years without treatment. Like the question that I really have, I wonder, what is the length of time that the average person that ultimately ODs as a result of being cut off, how long have they been cut off before they found themselves going to their street pharmacists for a solution?
Okay, we got about 2 minutes left, guys. We got about 2 minutes left. We got a couple people in. One more person in the waiting room who's trying to ask a question. Hey, J-Rock, can you hang up now? I'm not sure.
Yeah, I sure can. I'm sure can.
Thanks.
Appreciate you seeing you again, J-Rock. Take care, brother.
We got 2 minutes.
Okay.
I think okay. Got Lady Dreamer trying to admit. Yeah, please.
Oh, if you can, Tracy, we appreciate you.
I'm not sure. Hope I don't get kicked off it. I'm trying to admit. Well, it looks like I can't. It looks like I'm not able to admit
if she can put her question in the chat. If you're still with us,
Lady Dreamer and Joy, if you can put your question in the chat, we appreciate it. We'll get back to you later.
Yeah, we can try to answer it now. Because I'm looking at the chat right now. We had over 300 responses in the chat, but if they could put their questions in the chat, we'll try to.
Okay, so we basically got 2 minutes left. So there's like one last parting shot before we get back go. So we'll put this video up on Trump and the G, the YouTube page, probably by the morning. So if everybody can subscribe to the channel, like and share the video, we appreciate it. And we'll see you in a couple weeks. But that one last parting shot, Mr. Mitchell. We got 2 minutes.
Yeah, I think, we've stood on this square for a long time, like I said, a better part of 3 years. So for the folks that are joining us for the first time, definitely, check out the previous content, as well as in regards, to opioid and especially endo. But, our narrative has rarely changed. Things are not looking great economically. And to me, that is exacerbating this issue of folks turning to street drugs, because you cannot just cut out a solution and not give folks a replacement or an alternative for say a solution other than suck it up, buttercup, because that's pretty much what the current administration has said. And until that changes, we're going to continue to see the negation of the large majority of folks that actually need pain medications. And really, to this administration, I would say, pull your head out of your behind. The amount of money that has been federally allocated, like the ironic part is that for every person that's watching this, for every person that isn't watching this, you pay tax dollars. These tax dollars are going to the same federal agencies that are cracking down and taking away the solution that folks need for their pain. So we are funding our own barrier in a lot of ways. And that's a problem. And more people need to be outraged about this. More people need to be putting pressure on their congressmen and their senators, and their mayors and their state AGs. These are folks' offices that you can walk straight into as a state AG's office. These are folks that, if you live in a city that has a city manager, city council, aldermen, you need to be beating on their doors. You need to be putting boots on the ground over this issue, because until there is a mass outcry, there's too much money in this system to continue pushing this narrative that this is an opioid crisis caused by prescription drugs. So that would be my solution to this, that the masses of people put pressure on our policymakers to cut this foolishness out, get folks the solution that they need, which is getting more prescription opioids back into the folks' hands that actually need it.
Okay, great. I think this has been a pretty lively session. We covered a lot of territory. It's hard to cover all this in one session, but I think we did a decent job in trying to break down Dr. Kolodny's interview, and show the narrative, how his narrative may be different from what the reality is, and what a lot of people have been saying for years, that this is not a prescription opiate crisis. We have a drug problem in this country, and we're not going to be able to get to the bottom of it if we don't first diagnose it and then try to figure out where we go from here. But we got to start with debunking these narratives that people have a profit incentive to repeat, whether it's consultants, trial lawyers, or state AGs, or what have you, or the corporate media. I think the judges have done a great job of just putting their foot down and said, knock it off. I think a lot of activists, a lot of people in pain spoken up on social media, and we're here at Trump and GE, and we've been saying this for years. So I think people are hearing us. I think the judges are hearing us. I think some of the state AGs are hearing us in terms of trying to sell these cases and help to change the narrative. So that's Trump and the GE. Again, subscribe to the channel, the YouTube channel, and share the videos and like the videos. And so we'll let you know when our next event will be, but we're going to try to get down to the bottom of this and how we can, again, help change the narrative and move to action. Again, it's Trump and G for me and Mr. Mitchell. Thank you for joining us.
Yeah.